morning.
Good morning, Eirini.
Thank you very much for your invitation. You've honored me for once more. I'm very sorry that I could not be with you today because I've got a very important surgery. So I'm at Eirini Hospital, but this doesn't stop me from talking to you today. Today I'm going to prove that anesthesiologists are surgeons' best friends. That's what I'm going to prove once more. So making the lives of surgeons easier. The key points. How are we going to make your lives easier? By taking care of your patient, of our patient, as if it was one of our family members. The key points to that is a patient interview, which is very important. It's about 60% of the whole surgery thing. The airway management, the positioning of the patient, a clean surgical site so as to help you to perform your your operation better, the intraoperative management, pain control afterwards, and a quick discharge of the patient. So it's very important for us to win the patient. He must not feel fear. He has to be very confident when he comes to surgery. How can we do that? We have to answer some questions before surgery. 2 or 3 days before surgery would be the best. If it's something more easy as a surgery, we can do it the same day. So how much pain should I expect after surgery? We have to tell them exactly what kind of pain they're going to feel. If it's going to be very sharp, if it's going to be like pressuring on his arm or on his leg. These are the questions that patients are asking us. What is your approach to pain management? You know, internet is very good for everyone, but it can be very tricky for some people because they get to feel fear because of what they read. That's why we go to university for so many years, and they can ask us and we can answer every question. What combination of painkillers will be given? When does pain management protocol begin, before, during, or after surgery? And one of the most common questions is if our hospital has a standardized pain management protocol. So we have to let our patient share all his or her worries and offer reassurance. We have to have a meeting with the anesthesiologist, the patient, and the surgeon, of course. He has to feel as if we are of his own family. He has to tell us everything, and we're going to help him with all his fears. We have to persuade our patient about honesty, because he has to tell us everything, every allergy, every little thing that has happened during the years during another surgery. Knowledge is power. We're going to inform him about everything he's going to experience before, during, and after the surgery. We have to help our patients plan their lives for the week to come. If they need another person, another relative to be around them at home, etc. We have to check and handle the comorbidities. This is very important for us. If someone has got severe health problems, we have to be sure that he's going to be very safe during anesthesia. So something that is very important after we have sedated the patient is the airway management. Commonly, we use general anesthesia with either a supracrotidic airway or a tracheal tube, which is more common. There are multiple case reports in the literature of airway obstructions due to tracheal compression after arthroscopy because of the fluids. You can see it here, it's a bit swollen, so we're not safe to let the tube out of the mouth because he or she is not going to be able to breathe. So we have to wait after surgery for about half an hour, use furosemide, and make the whole area better. So this massive tissue edema can cause major difficulties. And it could lead to emergency surgical airway, which is very rare, but we should recognize it. This is the most important thing. Risk factors. factors. The positioning of the arthroscopy, the lateral decubitus positioning, the gravitational accumulation of fluids during the arthroscopy, high pump pressures, subacromial bursoscopy, and prolonged surgery. Another serious thing, which is one of the keys, is the positioning of the patient. We have to be the positioning of the patient is merely responsible. The whole team is responsible. The anesthesiologist, the surgeon, the nurses, everybody is responsible for the positioning. After general endotracheal anesthesia, we have to turn the patient to his right on his left for a decubitus position. Okay. This is the lateral decubitus, you all know it. A soft sheet is rolled into a cylinder, approximately 6 inches, and placed under the upper thorax to raise the patient's chest off the table, to minimize the pressure on the neurovascular structures within the axilla. Pillows are placed between the legs, and all the nerves and breasts are carefully padded. We use kidney rests, which are useful to support the bean bag, and broad adhesive tape for the head, for the knees, for the hands. We use an electrosurgical pounding pad. It must not be forgotten, and it is the first thing that anesthesiologists should take care of. If we have to ask if a grounding pad was used, because we can have severe damage to the patient if we haven't. The arm is placed on the lower drape, the upper drape is put into position, and the head is stabilized, because sometimes we rotate the table for 30 degrees. The eye should be tapped and padded very, very carefully, because we can have severe trauma of the eyes. Another positioning, the beach chair for the arthroplasty. The head and neck must be very, very carefully positioned. Pillows are placed under the knees. A foam pad protects the elbow on the other side. Pressure points must be carefully padded. The eye should be taped as well. So we have to keep the surgical site clear. How do we do that? We control the blood pressure. This is how we make the lives of surgeons easier. If you can see better, you can finish earlier, and you're going to be very happy. So this must be done with respect to brain flow. Less bleeding, high speed of performance, less volume of fluid into the arthrosis. So we're not going to have the edema in the tracheal tube. Less pain, less opioids, less time to discharge. We have to respect the brain. This is the autoregulation. So if we have MEAP, a pressure, mean pressure between 5 and 150 millimeters, we have a very good function of the brain. Before that and after that, we don't. We have to be very careful. Just we have to take care of the fact that many people that are having arthroplasty are of a big age. So we have to be very careful with their heart and their brains. Intraoperative management, hypothermia control. We use warm fluids, avoiding the overhydration, warm air close to the patient's feet, thrombosis prevention with elastic knee-high socks and Flotron, the pumps that are we're using for the thrombosis prevention, and control of nausea. We're taking care of the patient. We're thinking before, so as not to have nausea in the recovery room. Dexamethasone, ondansetron, bromperidol, IV fluids that are very, very helpful, and increase oxygen consumption. So another way, besides the intravenous medicines for analgesia, is the intra-articular analgesia that we're using here at Ygea Hospital. It's undertaken by surgeons and involves injecting local anesthetics plus or minus opiates into the joint space at the end of the surgical procedure. It is something we have served as a protocol We've said it before. It may also involve placement of an epidural type catheter for local anesthetic infusion. Our surgeons don't really like that, so we're trying to avoid it. So this is our protocol: the intra-articular analgesia, the local anesthetic, about 20 cc's, bupivacaine, bicarbonate, opioids, NSAIDs, tranexamic acid. Bicarbonate, why do we use it? As an adjunct, increasing the non-iodized form of the local anesthetics can reduce latency and prolonged duration of regional nerve block. And the warming of local anesthetics, we warm them at about 40 degrees Celsius for about half an hour. This decreases the pKa and also increases the ionized form of local anesthetics. So it helps the local anesthetic to stay in there and work for more. Why we use tranexamic acid? It inhibits plasmin formation, fibrinogenesis. It has got anti-inflammatory effects and may improve platelet function in certain circumstances. We use about 1 gram of tranexamic acid inside the arthrosis. We use the VAS scale afterwards to see if how much pain does the patient feel. 0 means that he doesn't feel pain at all, 10 that he cannot bear the pain. So we have got this protocol was a knee poster in the military medical convention in 2018, and we have proved that you can see the graphics that the patients that had all of this inside their arthrosis were more early discharged, and they didn't feel as much pain as the others that we only used the intra-articular local anesthetics. We've got another protocol running right now. It's the 1-day surgery for total shoulder arthroplasty. I know it's a bit, it is the talk of the days, but it's a new protocol. It's under construction. Where are we trying to plan? We need early patients discharge. That's what we're trying to do. They can leave in less than 24 hours, but we need to have the patient consent, because if someone feels fear, he cannot freely go. We have to sort out the patients concerning comorbidities, preferences, events during surgery. If someone had a heart attack during surgery, we cannot discharge them before 24 hours have passed. It needs patient training and analgesia plan. We can use an opioid anesthesia. Why not? Opioids are very good. We've talked about that in the mini battles some months ago. And we have to train the patient to take the painkillers at about 2 or 3 hours, even if he doesn't feel pain. We're trying for the first 48 hours to keep them in a program of pain control. I hope I've proven that anesthesiologists are your best friends. Thank you very much.